I think so, Doctor. We should start, Dr. Khola.
Sure, sir. So, sir, am I audible clearly?
Yes, perfect.
Thank you. So, assalamu alaikum, everyone. This is Khola here. I lately graduated in Pharm.D from US, and currently I'm working as research associate in LUMS Lahore. So, on behalf of Giving Back to Pharmacy in Pakistan, I welcome you all in today's session. Giving Back to Pharmacy is basically an organization of volunteer pharmacists from around the globe. Our vision is empowered pharmacists for better healthcare. So to continue the chain, we have Dr. Umair Ansari with us today. He will be mentoring about neurological disorders and their appropriate clinical management today. So before the proper commencement of today's lecture, I would like to share a bit about Dr. Umair Ansari. So he is a critical care pharmacist and residency program coordinator at Suburban Hospital, Johns Hopkins Medicine in Bethesda, Maryland, USA. He also serves as an adjunct clinical assistant professor for the University of Maryland School of Pharmacy. Dr. Ansari obtained his BA in International Studies from University of California and further completed his dual degree of Pharm.D and MBA from Harding University. He completed his postgraduate pharmacy residency program at Baptist Memorial Hospital, and he also worked abroad in the Middle East, not only as a critical care pharmacist, but also as an adjunct clinical assistant professor and also as pharmacotherapy lecturer. He has also obtained board certification as a critical care pharmacist and pharmacotherapy specialist. So thank you, Dr. Umair Ansari, for taking out time for today's session. Floor is yours now. So please proceed ahead.
Thank you very much for the introduction. I'll go ahead and share my screen if that's okay.
Yes, please.
Give me 1 second. Okay, just to make sure you can see my screen, correct?
Yes, perfectly, we can see it.
Okay, great. So I'll start. I'll be doing this overview of neurology, and this is from the ACCP Pharmacotherapy Board Review course, and I am attempting to summarize as much information as possible. I can provide the reference if needed later on, but we will try to get through as much as possible in this given amount of time. First, my disclosure. I will be discussing the ACCP book does discuss off-labeling use as well. So there's going to be both off-label and labeled use of medications because they are seen in practice, and it is important to know that. So the learning objectives, and these are pretty much taken from the board review course, but we will try to identify the different seizure types and status epilepticus. Will determine the appropriate use of anti-epileptic drugs and how their mechanism of action works, any adverse effects and drug-drug interactions. We'll also talk about stroke, so we'll talk about primary and secondary prevention. We'll also talk about acute stroke and how to manage that. We will talk about Parkinson's disease and how pharmacotherapy works for that disease state. We will also talk about headaches. So we'll talk about the different types of headaches. And then we will talk about multiple sclerosis or MS. And then finally, we'll briefly touch, if we have time, to talk about peripheral neuropathy. So let's just start from epilepsy. So epilepsy is the fourth most common neurological disorder. And basically it is described as brain activity when it becomes abnormal, and this causes seizures or periods of unusual behavior, sensations, or loss of awareness. And this epilepsy or seizures can be classified in several different types. So you have focal seizures, which is limited to one hemisphere of the brain. Generalized seizures will engage bilateral sides of the brain. Then you have seizures of unknown etiology or onset. And status epilepticus, I think the best way to remember what this is when you have seizures and they are prolonged after 5 minutes. And just I included some terms just for you to know if you ever come across them, when you are studying for the board or taking the exam. Prodrome is a term that means awareness of imminent seizure before it occurs. So maybe a patient may have some kind of feeling that's described as prodrome. And then aura is a focal seizure without loss of consciousness with memory, sensory and autonomic symptoms. So those are just a couple terms. Seizures can be described, as we mentioned, either focally or generalized, and there's different types. And this chart is supposed to help you kind of understand what type or what category the seizure may fall under. I'm going to minimize my screen just because I have some notes at the bottom. And I want to share with you that absence seizures, when you come across absence seizures, that is a brief and abrupt seizure, and it will last only 10 to 30 seconds. And that can occur in clusters. So patients with the absence seizure, they may actually have a blank stare on their face, and they may not be shaking or jerking. They'll be motionless, but they'll be having seizures. So that's called an absence seizure. Now, myoclonic seizure is a brief or rapid jerking movement type of seizure. So you'll have these jerking movements. A tonic-clonic seizure is where you will have flexion, extension, tremor, or clonic positions, and they'll last up to 1 to 3 minutes. And if you see here, this diagram kind of shows this flexion and extension movements of the body. And then we have clonic, which is just clonic jerking, which we just described. But this kind of helps differentiate where we are in terms of seizures. So it seems like there are more specifications when the generalized component of seizures is involved. So diagnosis-wise, epilepsy is dependent upon a physical examination, obviously, laboratory tests, and EEG, electroencephalogram, which is very important because that helps to confirm the diagnosis and to classify and locate the site of seizures. Then they can also have an MRI or CT scan performed if needed to determine even more specificity of the seizure type. So treatment, we're just going to start right away with benzodiazepines. And I've included in parentheses their scheduled type of medication. So it is a scheduled C4 medication. So anytime you see a parentheses, that means it is scheduled. So benzodiazepines, they obviously work on the GABA receptor, and we can use them for acute repetitive seizures or a first-line option for seizures in the immediate post-effect of a patient having a seizure. But the only things I guess you need to be aware of is that patients can have tolerance that may develop, especially if they have been taking benzodiazepines beforehand. So if they have a high tolerance, it may not be as effective. Use as adjunctive, so it is used sometimes in combination with other meds that may be needed for seizure management. And it is short-term therapy. And the most common agents that you'll see are clorazepam, clobazam, clonazepam, diazepam, and lorazepam. And there's also, as I mentioned, for acute repetitive seizures, you have intranasal options. And this is interesting because you can actually give the benzodiazepine through the intranasal route of administration if you are not able to give IV or PO or IM. So I'm going to try to pronounce this, brivaracetam. So it sounds like levetiracetam. So this is like the cousin of levetiracetam. This medication has an unknown mechanism, and it will have the same type of adverse effects. So as levetiracetam, so you'll have some sedation, dizziness, somnolence. Drug interactions commonly observed are carbamazepine, phenobarbital, and phenytoin. Now, this drug is probably a new option that was included in the updated ACCP literature for review because it was just approved it was actually just approved by the FDA, and it's the only cannabis product for epilepsy, and it's called cannabidiol. So it's a scheduled 5 controlled medication, and it is approved for this indication, and it is approved for seizures caused by Dravet syndrome or tuberous sclerosis and Lennox-Gastaut syndrome. So this is something maybe to keep in mind. By the way, I've tried to put things in bold just if I think they're, if they may end up asking you questions on your exam when you do take the exam, because they're somewhat of like hallmark signs of the drug or information-wise that you should know. So maybe this might be worth highlighting of the specific seizures that it is approved to treat for. So the adverse effects are sedation, drowsiness, diarrhea, increased liver transaminase. I'm not going to try to read all the information from the slides because there's a lot of drugs and I know we don't have enough time. So I'm going to try to briefly go over all the drugs, but I won't be able to read or share all the information, but please do refer to these slides for more specific information, okay? I'll just highlight whatever information I can about the drugs. So it does, it can cause hepatotoxicity if it is used with valproic together, and then be familiar with the dosing just in case that may be asked on the exam. Carbamazepine is a sodium channel blocker. And some of the adverse effects associated with this are specifically rash and syndrome of inappropriate antidiuretic hormone release, or SIADH. So this can happen, which can actually lead to maybe low levels of sodium in the serum blood. Aplastic anemia can also happen. As you can see, there is a component of allele testing that can be done, which can determine if there's a higher risk for Stevens-Johnson syndrome, which would be the HLA-B 1502 allele, and then the HLA-A 3101 allele, which will have an increased risk for hypersensitivity and a 3-fold elevated risk of macular-papular exanthema. Non-epileptic indication for carbamazepine is the trigeminal neuralgia. Cenobamate is a scheduled 5 medication, and this inhibits sodium channels, and it works on the GABA receptor. It does, or it could have a possible DRESS reaction, which is drug rash with eosinophilia and systemic symptoms. So the dose is titrated slowly. That's something to keep in mind. Contraindication would be familial short QT syndrome. Then we have the carbazepine acetate, which is a fast sodium channel blocker. It is a prodrug and it has active metabolites. And it is similar to the adverse effects are similar to those of carbamazepine, but may have a reduced risk of rash. And the dose is adjusted based on creatinine clearance. Ethosuximide, the important thing about this drug, it is a T-type calcium current blocker, and it's only useful for absence seizures. So remember that. Everolimus is for seizures caused by tuberous sclerosis. That's also worth remembering. And it's a kinase inhibitor. It is monitored by serum levels or trough levels in the blood concentration. And it has very specific monitoring. So if you look at the monitoring, every 1 to 2 weeks, the dose would be titrated every 2 weeks. When adding and discontinuing a PGP or CYP3A4 inhibitor or inducer, It should be monitored every 3 months. It should be, that's when a stable, on a stable dose, when your body surface area could be changing. So maybe a trough level should be drawn at that point, and every 6 to 12 months with a stable dose and body surface area. So as you can see, the more you take it over a longer period of time, the level of blood concentration monitoring can be reduced. Also, the dose is adjusted in severe hepatic failure. Fibromate is a medication that blocks the glycine site on the NMDA receptor, and it's only used when seizures are severe and refractory. So refractory means that you've tried several options of medications to treat seizures, but you're not able to resolve the seizures, and it's somewhat kind of like resistance to anti-epileptics. So you have this refractory seizure. So this is when this drug could be attempted to be used if needed for this reason. And again, the adverse effects, hepatotoxicity. You're going to notice a lot of these anti-epileptic drugs in general, a lot of these drugs do have hepatotoxicity as an adverse effect. So keep that in mind. A lot of these anti-epileptics are hepatotoxic in general. So this one also is hepatotoxic and, is hepatotoxic, and it can also cause aplastic anemia, and also a patient or guardian of a patient, if they're a child, must sign a consent form before the use of this drug because of this side effect. The next medication is fenfluramine, which has an unknown mechanism, and it is indicated for seizures caused, again, by Dravet syndrome in individuals older than 2 years. It has some contraindications, and it's only available through the REMS program. I'm sure you're familiar with the REMS program, which is the Risk Evaluation and Mitigation Strategies program. Again, it will require monitoring of some sort. Also keep in mind, there is an increased risk of serotonin syndrome when it is combined with other serotonergic drugs. Fosphenytoin. So this drug, I'd like to consider it kind of like the cousin of phenytoin, and it is a prodrug for phenytoin, and it's a fast sodium channel blocker, and it is used in the IV formulation for loading or maintenance dosing in place of phenytoin, and it's used for status epilepticus. So keep in mind, when we talk about status epilepticus, when we start that in the next few slides, treating status epilepticus.
Uncle, university का नाम क्या है? IUK.
Somebody's speaker is not mute.
Excuse me, sir. Oh, yes. Yes, please, Dr. Umair, continue. Mic is muted now.
Okay. So what I was saying is status epilepticus usually is treated by IV medications first, because, you know, status epilepticus is a very serious type of seizure disorder. So this is when fosphenytoin would be used in the IV formulation to treat that. For pharmacokinetics wise, it's an enzyme inducer, and it uses a non-linear kinetics. And one thing to probably memorize, I'm sure you'll get this question asked, but is the phenytoin equivalency of phosphophenytoin. So please memorize that 1.5 milligrams of fosphenytoin is equivalent to 1 milligram of phenytoin sodium, okay? So if you come across that, any kind of question, you should know the conversion. So typically, when you have to use fosphenytoin, you'll do a loading dose of 10 to 20 milligrams of phenytoin, and it's weight-based, so it'd be per kg, and it will be most likely IV. I guess, when you don't have an IV route of administration available, and then you have a maintenance dose, and that can be divided in divided doses throughout the day that can be given. Adverse effects, keep in mind, it can cause hypotension, perianal itching, and other adverse effects of phenytoin, which we will be discussing. And the advantages, here's also something important to remember, is when fosphenytoin is used, it's actually used because of these several advantages. And that is that it can actually be given as both IM or IV, and that phlebitis is actually minimized. So when they give the medication, you don't have to worry about extravasation from the blood vessels. And also the infusion time is actually up to 150 milligrams of phenytoin equivalents per minute. So in status epilepticus, the infusion should be at 100 to 150 milligrams phenytoin equivalents per minute. And this is actually higher than the phenytoin amount. So you can actually give more of the drug in a faster amount of time. It does have a maximum infusion rate, so it's important to remember not to exceed 150 milligrams PE per minute. And you can actually give the medication in either normal saline or D5W. Next, we'll talk about gabapentin. So gabapentin works on the alpha to gamma subunit of voltage dependent calcium channels. And it also, pharmacokinetics wise, it's not metabolized and it's eliminated renally. So you do have to be aware of patients with renal failure that you may have to adjust the dose, and for patients on hemodialysis. It can be used for seizures, obviously, that's why we're talking about it, but it does have a other indication, which is the post-herpetic neuralgia pain. And here's something to highlight, that doses can often exceed product information max of 3,600 milligrams per day. So basically there's a limit. You'll see that the manufacturer may have 3,600 milligrams per day, not to exceed this, but it can be done. If you needed to give a very high dose, you have at least 3,600 milligrams to work with, and even higher if needed. So that's just something to keep in mind. Here's the thing to highlight. I mentioned this with another drug, but with gabapentin, and we're going to talk about pregabalin as well, but these types of drugs have an increased risk of sedation and respiratory depression. When used in combination with other sedating medications or opioids, and also by itself, it is a side effect as well. So they will cause sedation. Glucosamide is a controlled medications category 5. It is a slow sodium channel blocker. It has a maximum dose of 300 milligrams a day, and it will be adjusted either renally or hepatically. The adverse effects can include a PR interval prolongation or first degree AV block. Lamotrigine, one thing to highlight from here is that it actually has a rash that can develop, and this is probably the most serious reaction of this drug, which is the primary concern, because the rash can lead to Stevens-Johnson syndrome or toxic epidermal necrolysis, which is extremely severe and deadly. So this is something definitely worth to remember and highlight, the rash part of lamotrigine, and that is why it must be titrated slowly to avoid a rash. There is a drug interaction with valproic acid. It will decrease the lamotrigine metabolism, so it can accumulate. Also, keep in mind, estrogen-containing oral contraceptives may actually increase lamotrigine clearance. So that means these oral contraceptives can actually induce the effects of lamotrigine. It is also used, by the way, for the maintenance treatment of type 1 bipolar disorder. We mentioned levetiracetam earlier, and we'll talk about it now. It is not metabolized extensively, and it also needs to be renally adjusted. The nice thing about this medication is that it does not have many drug interactions with other seizure meds. And this is one of the reasons why it has become kind of a favored medication or drug of choice to use when necessary, for several indications when seizures may be indicated or needed to be treated, or for prophylaxis seizure treatment. Adverse effects, we mentioned drowsiness, but also keep in mind it can cause behavioral changes, even agitation and depression, and the IV use will or can be used for status epilepticus. So sometimes this drug will be favored over phenytoin or fosphenytoin because it is easier to administer. The dosing is very simple. There's not many side effects or drug-drug interactions. Oxcarbazepine is, again, another fast sodium channel blocker. It does have an active metabolite. It will act as an enzyme inducer, and it will decrease the effectiveness of hormonal contraceptives. So that's something to keep in mind. One thing to highlight is it also can cause hyponatremia, more common than with carbamazepine. So this is the bigger agent of possibly causing hyponatremia. I mentioned hyponatremia with the carbamazepine, with the SIADH syndrome. So this can also cause this. Perampanel is a controlled class 3 medication. It works as an antagonist of the AMPA receptor. It is protein bound to albumin. It has an extremely long half-life of 105 hours. And it does have adverse effects, neuropsychiatric effects, dizziness, gait disturbance, weight gain. We have phenobarbital, which is a category 4 medication. This can also be used to treat seizures. It works on the GABA receptor, and the big side effect of this, it's not listed here, but it can cause hypotension, hyperactivity, and cognitive impairment. It can also be used for anxiety and severe alcohol withdrawal. Phenytoin, so we mentioned fosphenytoin earlier, but phenytoin is actually an enzyme inducer, and it uses nonlinear kinetics. So the issue with phenytoin is that we mentioned the benefits of using fosphenytoin, and the reason is that the maximal infusion rate, as you can see, is much lower. It's 50 milligrams per minute. So this is something to remember. You can't exceed the max infusion rate of 50 milligrams per minute. The reason for that is because of the risk of cardiac arrhythmias and hypotension. And it can only be prepared in normal saline. So if you remember fosphenytoin, that could be also prepared in D5. The dose-related adverse effects are nystagmus, ataxia, drowsiness, cognitive impairment, and the non-dose related adverse effects. One of the big ones is the gingival hyperplasia, which is something in the oral cavity. It is hepatotoxic, so do remember that as well. Pregabalin, similar to gabapentin, this is a controlled 5 or category 5 medication. It's also not metabolized, so it is definitely, it can accumulate, especially with reduced renal function. It can cause drowsiness, blurred vision, weight gain, edema. Edema is something that can also occur in the patients that are taking gabapentin. It's just one of the side effects. It can cause creatine kinase elevations. It also, important thing about this medication, it also needs to be tapered, but it can cause side effects if there's an abrupt discontinuation. The non-epileptic indications include neuropathic pain, similar to gabapentin for diabetic neuropathy, post-herpetic neuralgia, spinal cord injury, and fibromyalgia. It will also increase the risk of sedation. We talked about this with the other options. Here, I actually wanted to just, I'm sharing this from the actual chapter of ACCP, and these are medications that are used, all the medications that we talked about that are used for the different types of seizures. So I think it's a good idea to become familiar with this list and just memorize which drug can treat which type of seizure. So, and they're all categorized from 1 through 5. So when you see a 1, that would be considered first line. 2 will be considered second line. 3 will be considered as having some therapeutic effect. 4 is considered adjunctive therapy, and 5 is only used when benefits outweigh risk. And actually, I forgot, there's also 6. 6 means in combination with clobazam. So for example, I mean, I'm not going to go into details with this, but as you can see, for let's just look at the first drug, brivaracetam, is listed as number 3 for focal seizures, and it has some therapeutic effect. So it will not work for all the other types of seizures. But if you take a look at fenfluramine, which is a medication in the middle of the list, that is indicated specifically for Dravet syndrome with a number 5. That means used only when benefits outweigh risk. So pretty much become familiar with this chart. I think it'll help you kind of memorize and determine which option is first line, second line, which may not work, and so forth. This is also a big list, but I didn't know how else to share it with you because I feel like you should become familiar with this, and this is because of the different drug-drug interactions that are possible with the seizure type medications, because there's a lot of drug-drug interactions, and we've talked about that. So if you look, there's anti-epileptic drugs, and then say there's one anti-epileptic drugs, but there needs to be added a second agent. So when you add a second agent, what will happen to the initial seizure medication? Either will it have a drug interaction of inhibition or induction, and then the mechanism will determine. I think if somebody can silence their or mute their speaker.
Yes, Dr. Umair, I muted them. Please
Okay.
proceed. And I apologize for the disturbance, actually.
No problem. So as I was saying that we have medications here, and the drug interaction, either it's going to be an inhibition type of reaction or a induction type of, or inducer type of reaction, where you're either increasing serum concentrations or reducing serum concentrations. So that is all listed. So you have to look at each of the drugs and be familiar with what drug. And if another drug, for example, let's just look at on the first list, brivaracetam. So if phenobarbital or if phenytoin or if ethosuximide is added to the first agent, what will happen to the initial medication? And as you can see, there will be a change in serum concentration. It will be a decreased effect. So that the other added medications will actually increase the metabolism of the first initial agent. And that is the mechanism. So try to become familiar with this list, look at it. This is a continuation of the list. As you can see, valproic acid has a lot of drug-drug interactions when a second agent is added. Mostly it's decreased effects on the initial drug, but you can see with Fibromate, when it's added to valproic acid, it will actually increase the serum concentration of valproic acid. So it will cause an inhibition type of reaction. I know that's a lot of information, but try to just become familiar with that list. So we're going to continue with the drugs. We have primadone, which works on the GABA receptor. It's also used for essential tremor. That's something to keep in mind. I'm going to try to get through these drugs. I know there's a lot of drugs, and I just wanted to talk about them because it's good to be familiar with these drugs because they can show up on the exam. And there's a lot of drugs, so it's better that you be familiar with them. So I'm trying to target all of them. Primadone, so I mentioned for essential tremor. Rufinamide also works on the sodium channel blocker. It also has something to highlight. It has an FDA indication only for Lennox-Gastaut syndrome. So that's something to keep in mind with rufinamide. Okay, can you hear me now? I think I was muted for a second. Okay.
Yes, we can hear you now.
Okay, good. So I was just mentioning that rufinamide has an FDA indication only for Lennox-Gastaut syndrome. Okay, next is the stereopental medication, and this is indicated for Dravet syndrome, and it's used in combination with clobazam. Another medication we have is tiagabine, and this works on the GABA receptor. and it's actually FDA approved as adjunctive treatment for partial seizures. So that's something to remember for this drug. Topiramate, it can actually be used for non-epileptic indications like prophylaxis of migraine headaches, but also can be used for seizures as an option as well, because it works on the GABA receptor and AMPA receptor as well. And it is also a weak carbonic anhydrase inhibitor. Valproic acid, this is the medication we've talked about several times, but the important thing to remember about this is that it will have a lot of drug-drug interactions. The mechanism is that it works on the calcium or T-type calcium currents. It blocks sodium channels and it works on the GABA receptor. It is an enzyme inhibitor, so definitely will cause many drugs to accumulate, so it will reduce their metabolism. It will be used or can be used for status epilepticus, as well as any other seizure disorder. And also, it can also be used for non-epileptic indications like manic episodes, for bipolar disorder, or prophylaxis for migraine headaches as well. Vigabatrin also is a medication working on the GABA receptor. It has induction with the causes or induction with the CYP2C9 enzyme. It is renally eliminated. One thing to remember about this medication is that it's only used for refractory complex partial seizures and infantile spasms. So that's one thing to highlight with this drug. Zonisamide is a sodium channel blocker, works on the T-type calcium currents. It's also a weak carbonic anhydrase inhibitor. For this drug, avoid insulfa sensitive patients. So sometimes it can be used in patients with non-serious sulfa allergies, particularly with non-acrylamides such as sulfonylureas, has been used successfully. So that's one thing to kind of keep in mind if a scenario or patient case is presented and this is what is mentioned about the patient. So keep that in mind. This is a slide that I created to be familiar with the therapeutic serum concentrations of all seizure medications. So I put it all together. Here are listed all the medications and their therapeutic serum concentration. So being familiar with this will help in terms of maybe a question being asked, what would be a therapeutic serum concentration? So for example, for valproic acid, anywhere from 40 to 150 micrograms per ml would be considered a therapeutic serum concentration. Status epilepticus, finally we get to this disease state, which actually involves a process. So we'd treat all underlying principles, reverse any reversible causes that will be determined by lab values. So for example, if a patient, we check their blood glucose and they end up being hypoglycemic, hypoglycemia can cause seizures, right? So it is recommended that we actually give thiamine 100 milligrams followed by dextrose, and then obviously treat the seizures. Now there's a process on how to treat the seizures. So you have to give an emergency medication to stop the seizure immediately. And then you follow that up with an urgent medication to prevent the recurrence of seizures. So we'll talk about the emergency medications and the urgent medications step by step. And all of the drugs, as I mentioned earlier, need to be given IV, and neuromuscular blocking agents do not stop seizures, FYI. So we're going to start with the emergency medications. So as I mentioned, benzodiazepines, so lorazepam is considered the drug of choice. So please highlight that. It has a rapid onset of action and it can be dosed 0.1 milligram per kg at a rate of up to 2 milligrams per minute, and it can be repeated several times. Diazepam, also a rapid onset, short duration medication. Midazolam is preferred for IM administration. So that's something to remember because midazolam can be given IM if for some reason you did not have IV access. It can actually also be given intranasally as well, or buccally as well. So it is a rapid onset and short duration as well. So these are the emergency type medications. Now for urgency medications, these are the medications that would be followed by or given after the emergency medications were given. So you can give any of these options. So we have already mentioned phenytoin. We've talked about fosphenytoin, phenobarbital, valproic acid, levetiracetam, and glucosamide. These are all options. But if you see, FDA has not approved valproic acid, levetiracetam, or glucosamide for status epilepticus, but in practice, we are using levetiracetam, or even valproic acid. They are used in practice. You will find literature also showing this, but commonly phenytoin, fosphenytoin, and levetiracetam are the common agents you'll see in practice for status epilepticus. So this is a refractory status epilepticus, and this is when we consider agents where seizures are not resolved after giving the emergency type medications, and now you have some type of resistance. So this is where you can consider other alternative medications, and that would be other barbiturate therapy like pentobarbital or thiopental. And these will be given all as infusions, okay? These are all given as continuous infusions. You have midazolam, which can also be given as a continuous infusion. You can have propofol also be given as a continuous infusion. And keep in mind with propofol, you have to be aware of the propofol-related infusion syndrome reaction if the administration is prolonged. And also keep in mind, all of these agents will cause severe hypotension, respiratory depression, cardiac depression, and that is why they must be on a ventilator. So if we have a mechanically ventilated patient, we don't have to worry about many of these things, but just keep in mind that hypotension can happen and that may need to be addressed with another medication to increase their blood pressure. Special populations in terms of seizures. Older adults, definitely we know that their pharmacokinetic changes in older adults are reduced and diminished, so they will have different and various effects on their absorption, distribution, metabolism, and elimination. So they will have decreased clearance if a patient is taking carbamazepine. They'll have decreased protein binding. If a patient has low albumin or renal failure with phenytoin, they'll have decreased protein binding with valproic acid. The half-life of diazepam could be increased. Lamotrigine will have decreased clearance, and also phenylethylmalonidamide will also have a decreased clearance if their renal function is also poor. For women, women of childbearing age should not be given valproic acid unless other therapies have failed. So this definitely will be a typical patient case that could happen and you could be presented with maybe on the exam. So just remember that valproic acid is not a drug, is not recommended for women of childbearing age. Also, if patients are taking hormonal contraceptive therapy, you have to also be aware of that because there can be a decreased effect with their contraceptive medication if they're taking medications that have inducing type pharmacokinetic activity, and they can actually increase the metabolism. It is recommended that women, if they are taking seizure medication, to only take monotherapy if possible, and that's just to avoid all the different types of side effects. And also, it's important for women to take folic acid supplementation. So when this is the actual discontinuation criteria. I know I don't have much time, so I'm going to try to get through as much as possible. When medications are discontinued for seizures, and there has to be a particular criteria of how to discontinue them. because you don't want to have withdrawal from seizure-like activity. So patients should be seizure-free for 2 to 5 years on seizure medications. This is a part of the criteria. They should also have a single type of focal or generalized tonic-clonic seizures. They should have a normal neurologic exam. Their EEG should be normal with seizure medication treatment. And if a drug is discontinued, it is usually tapered for several months. So keep that in mind if a patient is qualified to stop their anti-seizure medications, it has to be tapered off, not an abrupt discontinuation. Sexual dysfunction has been reported with certain medications. From here, just remember that if sexual side effects is a concern, medications like lamotrigine or oxcarbazepine can improve sexual functioning if this is an issue for a patient. Now we can get into ischemic stroke. And I'm going to try to summarize as much as possible. So I'm not going to try to read the definitions, but try to know the difference between a CNS infarction and ischemic stroke. So an ischemic stroke basically is where you have a neurologic dysfunction and it's caused by either a focal, cerebral, spinal, or retinal infarct. There are several risk factors. They're categorized as either non-modifiable, somewhat modifiable, or modifiable. And there's a difference between, say, age, race, ethnicity, or sex, disease state like diabetes, or modifiable risk factors like underlying conditions like hypertension, or patients are smoking or taking oral contraceptives. This is just a visual to show you the difference between ischemic stroke and hemorrhagic stroke. So our focus is on ischemic stroke. So there's no bleeding involved, but when there is bleeding involved, it will be considered a hemorrhagic stroke. So the primary prevention for stroke or ischemic stroke is reducing the risk factors, obviously, educating the patient about the warning signs, and treatment of AFib if that is present. And I don't want to go into this too much, but you have to calculate the CHAD2 VAS score and figure out what score they're assigned. And based on the score, you can determine should the patient be treated with an aspirin or antiplatelet agent, or oral anticoagulation, or no agent at all, depending on the score. So based on that, if a anticoagulant agent is used or needed, patients can either take DOACs or the novel oral agents like the dabigatran, viroxaban, apixaban, edoxaban, or the familiar medication of warfarin if needed, based on the CHADS2 VAS score. Also, when we're treating ischemic or treating acute strokes, heparin is usually not recommended for stroke treatment at therapeutic doses because it can actually increase the risk of a hemorrhagic transformation. So that's something to keep in mind. From here, I just want you to remember that usually TPAs, or tissue plasminogen activator alteplase, is the drug of choice here for ischemic stroke. And keep in mind the window, you have a 4.5 hour, up to a 4.5 hour window from symptom onset. So it's a 3 to 4.5 hour window, but you have a maximum of 4.5 hours to give the medication. And you have to memorize this dose because this will definitely be on the exam to know the dose of the alteplase for treating ischemic stroke and how to administer it. Something important to remember is antiplatelet agents should be held for 24 hours after the administration of a TPA for this indication. And patients with a minor stroke or TIA, they can receive dual antiplatelet therapy with either aspirin and clopidogrel and continued for 21 days. Sometimes patients will get a clot retriever procedure, and this is when they get a thrombectomy. They remove the clot, and that can be performed in several patients with or without prior TPA. Exclusion criteria. This is something all of you should be familiar with, the exclusion criteria, because not every patient qualifies for a TPA. So be familiar with this criteria. Obviously, I don't have time to read all of it, but look at the criteria. If a patient meets any of these criteria, they may not qualify for TPA. So be familiar with this. Secondary prevention for ischemic stroke is reducing all modifier risk factors. Carotid endarterectomy, carotid angioplasty, and stenting. Aspirin, we talked about, so talking about the duration of aspirin or antiplatelet therapy after a minor stroke or TIA. After a major stroke, dual antiplatelet therapy with aspirin and clopidogrel should be initiated for up to and continued for 90 days. So remember that for a major stroke, it's much longer. And then also after 90 days, they can transition to a single antiplatelet therapy and they will be continued indefinitely. So a patient may be on aspirin lifelong if needed. Parkinson's disease, I just want to briefly get into this. It's a brain disorder that leads to shaking, stiffness, difficulty walking, talking, balance, and coordination. And these symptoms will begin gradually getting worse over time. It is not, it cannot be reversed. So it will worsen. And the treatment primarily involves dopaminergic treatment, and you'll either use agents like dopamine agonists or levodopa. We'll get into this treatment. So levodopa will primarily improve motor disability. So if you're reading about a case and their motor dysfunction and you have these options, levodopa will definitely improve motor disability. Dopamine agonists will actually lessen motor complications. And using several different classes of medications simultaneously is common. So you can use more than one agent. We'll discuss that briefly. So these are some of the signs and symptoms. Medications, we'll start with the monoamine oxidase type B inhibitors. You have salicyline, residuline, and sulfonamide. Then you have the adenosine receptor antagonists. And this is estradiol, and it's used with carbidopa levodopa, and it treats off episodes. What I mean by off episodes is with carbidopa levodopa, you have these phenomenons of wearing off and on-off phenomena, and that's basically where the medication will either start wearing off the effects of the drug at a certain time in the day or certain time period after receiving therapy. So treating these off episodes is when this medication would be used as adjunct to carbidopa levodopa. Levodopa is available as an inhalation powder. Carbidopa by itself is available, but the combination carbidopa levodopa is something that is commonly used. It needs to always be titrated. So it needs to be adjusted and titrated to its most effective dose for the patient. Keep in mind, high protein diets will decrease the absorption of this medication. And the long-term adverse effects we mentioned, this wearing off and on-off phenomena, which can happen, and involuntary movements, dyskinesias can also occur. Then you have the direct dopamine agonists. These are your agents like apomorphine, bromocriptine, pramipexole, ropinirole, and ritogatine, which is a transdermal patch. You have anticholinergic options, trihexyphenidyl, benztropine, and these are only useful for tremor because the tremor-like side effect can occur due to other medications. You have amantadine, which can reduce dyskinesia caused by levodopa or dopamine agonists. So you have medications treating the side effects of other medications. Then you have the catechol-methyltransferase or COMT inhibitors. You have tolcapone, which can be hepatotoxic, and tacapone, which must be used with carbidopa levodopa. And you have opicapone. And also rivastigmine has an FDA indication for Parkinson's as well. So another thing to keep in mind is hallucinations or psychosis due to Parkinson's is possible. And if this happens, it is recommended to first discontinue or reduce the Parkinson's disease medication dose as tolerated, but you could also give quetiapine or clozapine to address this psychosis. And there's FDA approved medication called pimavanserin, which is actually approved for this indication for Parkinson's disease psychotic disorder. So keep that in mind and highlight that. Jumping into headache, I think we're almost finishing up. I think I may have just a few more minutes. Headache, there's different types of headache. There's a migraine with aura, there's a migraine without aura, there's a tension headache, there's a cluster headache, there's analgesic rebound headache. Please read into obviously I don't have time to go into all the definitions, but read into these different types of definitions and the treatment. There is a lot of medications that actually treat or can be used for giving for migraine prophylaxis. So I've actually written, please see the ACCP chapter, because there's a list of meds that you can look at and be familiar with. It's extremely long, but if you're familiar with the names of the medications, I think it will help guide you when choosing the right option. However, for treatment, for having a migraine, acute migraine, for treating, you commonly use agents like triptans, ergots, lamivudine, ubrogibant, and rimegibant, and NSAIDs, opioids, and even antiemetics can work. For tension prophylaxis headaches, you can use tricyclic antidepressants and even botulinum toxin. For acute treatment, for a tension headache, you can use acetaminophen and NSAIDs. For cluster headaches prophylaxis, you can use verapamil. Even melatonin will work, and you can use suboccipital injections of betamethasone. So that means giving some kind of injection in the head area. And lithium can also help with this. Even warfarin is listed as possibly helping with cluster prophylaxis. And you have your acute treatment listed as triptans, even oxygen, intranasal lidocaine can help, octreotide can help, and even 10% of cocaine can help with cluster treatment headaches. MS, this is the last condition. I'm almost done. Last disease state for me to discuss. It is defined as an autoimmune disorder with areas of the CNS. It'll cause demyelination and axonal transaction. It is classified in these different categories. Please look at this just to familiarize yourself with the different types of classification. There's 4 types. And the treatment, again, if you have MS, you are treated with high-dose corticosteroids. So it's definitely recommended that you be familiar with the dosing. So for IV methylprednisolone, it will be a dose of 1 gram in a day, and this can be 1 dose or divided doses for 3 to 5 days. You can have oral prednisone, and that can be a dose of 1,250 milligrams in a day. And then you can also have IV adrenocorticotropic hormones, and then you have your disease-modifying therapies. I won't name all of these drugs. Please look further into the chapter about each of these agents, but these are all the disease-modifying therapies available. So look at that in detail to get more specific information. You have treatment continued, so you have symptomatic therapies. So if you have fatigue with multiple sclerosis, you can use amantadine, you can use methylphenidate. If you have spasticity, you can use baclofen, tizanidine, dantrolene, diazepam, even intrathecal baclofen can be used, and botulinum toxin can also be used. If there's some kind of walking impairment, you can use dalfaprimidine, and then for pseudo-bulbar effect, you can use the dextromethorphan quinidine combination. And Alexa, thank you all very much. And please, again, please refer back to the ACCP book for the headache specifications on the drugs, and more so on peripheral neuropathy, because there is just not enough time to get to that. Also refer back to the book for the MS component if you want to go into further detail with the drugs. Otherwise, thank you very much.
So thank you so much, Dr. Umair. Now I would like to address to the participants. If anyone is with any question, then please feel free to ask. I have basically permitted all the participants, they can unmute themselves. So please feel free.
Sure. And I think there are some questions on the side. So
Great.
I guess I'll read the question, okay?
Sure.
I'll read the question. So I think the first question is, can we give topiramate plus sodium valproate plus, I think it's levetiracetam plus sertraline plus glucosamide to an anti-epileptic patient? That's a great question. But I'm also trying to wonder, in what context is all of these drugs being given? Does the patient have like status epilepticus? Do they have like an underlying underlying condition like depression or some kind of psychotic or bipolar disorder? You'll use a lot of different agents, right? But I think one thing to remember is that keeping in mind the drug-drug interactions, okay? So as a pharmacist, I'd probably tell you to look into the different medications one by one and see if they interact with each other and see if they can cause severe interactions, or not only just causing inhibition or induction or increasing the metabolism, but also like serotonin syndrome, the risk of serotonin syndrome that can also be happen. So most likely, here's the other thing to mention is that you can use many drugs, but you want to make sure you're also optimizing the dose of your drugs too. You don't want to keep adding medications. So like if you're using valproic, you want to make sure you're giving a good dose. If you're using levetiracetam, you want to make sure you're giving a good dose, not a low dose, before adding on other agents. I think there's another question. Can we give tablet levetiracetam 2 grams BID? Yes, you can. I've seen that before, and it depends on what you're treating though. So if you're just treating, if you're not treating status epilepticus, which I mentioned, you treat IV, right? You use IV always for status epilepticus. But if you're not treating IV, if you're not treating status epilepticus, you can give tablets or oral solution if needed. So any other questions?
Yes, sir. I have one question regarding status epilepticus. You have mentioned that diazepam or lorazepam we can repeat several times. So how many times maximum we can repeat, like 5 times, 10 times? Because as we know that for every drug there is a maximum limit. So what you will say about that?
Yeah, so for these drugs, there actually is not a maximum limit, because if you have status epilepticus, right, you give the benzodiazepine. So you give lorazepam or you give diazepam. Now you give these drugs because you remember we talked about urgent medications and emergency medications for treating seizures. So in the first moment of onset for seizures, you give a dose and you see the effect of it, right? Because you want to stabilize the seizure first. So say, for example, and I've seen this with my own eyes, where you have a patient and maybe they're in the hallway and they're walking, and then all of a sudden they fall to the ground and they start having a seizure. Now, the first medication you're going to give is going to be lorazepam or diazepam if you have it. You're going to give one, and then we talked about midazolam. Midazolam can be given IM, right? So if we don't have IV access, we can use the IM route. We'll give one shot of midazolam. We'll see how the patient reacts. You have to first stabilize the seizure as quickly as possible, because it may not be you may not be able to start the other medications that may be needed, such as the phenytoin or fosphenytoin or even the levetiracetam right away. So the key would be to stabilize the patient somewhat until the other medications can arrive, and then you can give the patient the other medication. So it's kind of like give the lorazepam and the diazepam agent until the other medications can arrive, and then you can kind of monitor the situation then. I hope that answers your question. So it's like you want to give you can give lorazepam, you can give diazepam, one injection every, you're not waiting for a long period of time. So if you give it starting at time 0, you can give it again, maybe time 30 minutes or 1 hour, but usually, you would have the medication from the pharmacy by then.
Thank you so much for sharing your thought. Thank you.
Yeah, no problem. Any other questions? And you guys, if you have more questions too, and if you don't want to address it here, you can email me or, contact me if you have other questions. And if you have the ACCP book chapter, you can look at that. If you have more questions, you can ask me from there too.
So if anyone is with any other question, he or she may ask. Otherwise, I would be concluding the session. And Dr. Umair, if you would be easy to share your email in the chat box, then please do. Participants would be taking your email from there.
Yes, I will put my email address right now. So whoever needs it, I will. I've shared my email address so you guys can email me there.
Great. Thank you so much. So everyone, this brings us to the end of today's session. Once again, on behalf of Giving Back to Pharmacy in Pakistan, I would like to thank you, Dr. Umair Ansari, for taking our time, and all participants for attending today's session. Finally, thank you to all volunteers as well for their tremendous efforts in making these sessions a success. I will now end the session with a kind reminder for everyone to join us on Tuesday for our next session that would be delivered by Dr. Rana Kamran. Lots of exciting stuff and worthy concepts also would be waiting for you there. So stay safe and Allah Hafiz. And thank you, Dr. Umair, once again. This was a beautiful session.
Thank you very much. Allah Hafiz.
Allah Hafiz.